Excellent. Thank you everyone for joining this afternoon. The topic for today's Catalyst seminar is the understudied majority, adolescent mental health in the global context. And just for those of you who are newer to the Catalyst seminars, these happen every month in term, and the aim is to really try and get everybody at UCL to think about collaboration and questions. So we're hoping today's session will lead to lots of questions, and so we will have time for questions. And the plan is that we will have 20 minutes each presentation, with immediately afterwards 5 minutes for questions related exactly to that presentation. But then we will have a panel discussion where we will open it up to more general questions around this topic more broadly. Just to sort of introduce the topic and why I picked it for this. So every year I'm asked to organize and chair one of these Catalyst seminars on the topic of inequalities. And this year I decided to focus on what I think within the research and knowledge landscape is probably the largest inequality of them all in child and adolescent mental health, which is that although 90% of the world's young people live in low and middle income countries as defined by the World Bank, really, I mean, from what we know about RCT, so intervention research, about 10% of intervention research happens in low and middle income settings. And when it comes to the type of research that I do, which is sort of population-based determinants, causes, development, even less. So you regularly see sort of systematic reviews in terms of longitudinal analyses and mental health research, where there will not be a single sort of data set or research from a low and middle setting included. So everything we know about how mental health develops, causes, consequences, we know from a really small handful of very high income European, mainly European, North American, mainly white majority countries. So with that in mind, I'm very excited to introduce our two speakers today. I will introduce each properly for their talk, but just to say both Tom Steare and Kelly Rose-Clarke are researchers at UCL who are trying to change this. And one presentation, so Tom's presentation will be more about determinants, development, longitudinal data, and Kelly's will be more about intervention development. And with that, I will introduce Tom. So Tom is a final year PhD student, funded in the Wellcome Trust Mental Health Science PhD program we have here at UCL. His research focuses on the social determinants of mental health, with a particular focus on how economic circumstances affect the mental health of children and adolescents in more than one context. So he's using sort of, you'll see his work now, so I won't say much more, other than to say lots of the work you present today requires a lot of data management analysis skills, and he's an absolute whiz with data, but also has involved researchers from all of these countries in his research, which I think is really important aspect of how we do research in more global settings. And on the side, Tom also likes to be a meta-analysis detective, not intentionally, but accidentally, but he's basically now found major falls into meta-analyses, quite important meta-analyses in this area of research. So yeah, so if you're doing a meta-analysis, you might want to really think about everything that's going in, because Tom might find a mistake one day. And with that, I will hand over to Tom.
So as I was saying, economic disadvantage is associated with an increased risk of mental health problems, and this is the case in adolescents too, with different indicators of social and economic disadvantage, such as parents' education level or their occupation, or different indicators of economic circumstances, such as income or subjective wealth, associated with adolescents' mental health problems. As Praveetha has touched upon, most of this research has focused on countries in Europe and North America, which is obviously problematic, given that 90% of the 1.3 billion adolescents that live in this world reside in countries in South America, Asia, and Africa. So this means that we have a limited understanding of economic inequalities and mental health in the countries where most adolescents live. And by focusing on countries within specific regions, such as Europe or North America, it means we limit our understanding on what different societal or contextual level factors may have in shaping inequalities in mental health. So for the first part of my PhD, I was interested in looking at the association between food insecurity and suicidal thoughts and behaviours in adolescents. and trying to look at across many different diverse countries as possible. So food insecurity can be defined as a lack of regular access to enough safe and nutritious food for normal growth and development. Estimates suggest it's experienced by 2 billion people at some point within each year. It's commonly linked to households' economic circumstances, so things such as income, where it's also linked to other wider factors such as care or health, and also macro level factors such as conflict or agricultural performance. Food insecurity in adolescence is linked to a range of outcomes, including social outcomes, which can have impacts on adolescents' relationships with their peers or parents. Also impacts their educational outcomes, their physical health and mental health, including suicidal thoughts and behaviours. However, most of that research has been taking place in high-income countries. That's linked suicide and food insecurity in adolescence. And this is obviously problematic because there's different factors linked to a country's context and society may influence how food insecurity and suicidal thoughts and behaviours are related to one another. For instance, thinking about relative deprivation and how that occurs within a country, it's feasible that living in a country where food insecurity is a rare experience and experiencing food insecurity yourself, that may be more harmful for mental health and potentially associated with more severe social and psychological impacts as a result of being more marginalised within that society. And there's also a lot of interest regarding economic inequality within countries, assessed through measures such as the Gini index, and how these may be linked to greater inequalities in mental health and physical health outcomes. Within countries, the level of healthcare and accessibility may also be important in influencing the extent of inequalities in suicidal thoughts and behaviours. So where healthcare might be accessible and high quality, that might help prevent suicidal thoughts and behaviours. But however, if there are inequalities in healthcare access linked to food insecurity or economic circumstances, this may lead to inequalities in health outcomes. And also a country's national wealth or economic development may also impact how food insecurity is linked to suicidal thoughts and behaviours. So we were therefore interested in looking whether food insecurity was associated with suicidal ideation, suicide planning, and suicide attempts in adolescents across 83 different countries. We specifically wanted to know whether the strength or direction of that association varied across countries and whether it was linked to specific country level factors. So to do this, we used data from the Global School-Based Student Health Survey. This is a survey run by the World Health Organization across 104 different countries and features samples of school-aged adolescents between the ages of 13 and 18. And of the 104 different countries, 83 had data on suicidal thoughts and behaviours. So these are the results for suicidal ideation, but they are broadly similar to those for making a suicide plan and suicide attempts. So in about 2/3 of countries, there was evidence that experiencing food insecurity was associated with increased risk of experiencing suicidal ideation. And in the map figure here, countries that are in lighter blue, the association is greater compared to countries that are a darker blue, where there's almost no association at all. And this cross-country variability is also highlighted in the forest plots here. And as you can see at the top, there's a number of countries where there's no association at all. But at the bottom, in countries such as Cambodia and Myanmar, adolescents that were food insecure had a triple risk of experiencing suicidal ideation compared to food secure adolescents. So this therefore points that potentially the societal context within these countries may be influential in establishing the extent of these inequalities. And of course, we looked at this and we found a particularly strong relationship between how common food insecurity was within a country and the extent and magnitude of the association between suicidal ideation and the other outcomes with food insecurity. So within the figure here, you can see as food insecurity becomes more common in a country, the association is much weaker compared to countries where it's much less common. And this was in line with our hypotheses and based on the idea of relative deprivation and experiencing a economic risk factor that is much less common and more indicative of a marginalised position in society would have a more negative impact on your mental health. We also found that in high-income countries and countries with greater levels of universal health coverage, to our surprise, was linked to a more stronger association between food insecurity and suicidal thoughts and behaviours. However, this was primarily explained by co-occurring low levels of food insecurity within these countries. And we also found no difference across countries according to levels of income inequality within them. So conclusions based on this study, we found that in most countries, but not all, suicidal thoughts or behaviours were more common in adolescents that were food insecure compared to food secure adolescents. We found variation across countries and also between different measures of country level context. The main advantage of the data we analysed was that we were able to cover a diverse range of countries from different world regions, including countries that are typically not included in mental health research. However, the sample was school-based and the data was cross-sectional, so findings may not expand to the national level, and also may be at risk of bias owing to the cross-sectional nature of the data. So because of this, our next step was to then look at a longitudinal association between economic circumstances and internalising symptoms across 8 different countries. So we're interested in knowing whether there's cross-country variation in the magnitude and direction of the association between 3 different measures of economic circumstances and future internalising symptoms. These measures were household income, household consumption expenditure, referring to the values of goods and services bought by a household, and also adolescents' subjective wealth. We also wanted to know whether within countries do objective or subjective measures of economic circumstances explain greater levels of variance in internalising symptoms. So to do this, we identified 5 different cohort studies carried out across 8 countries. All these studies had measures of economic circumstances, mental health in adolescents, and we judged to be sufficiently comparable in their methods to enable to study them together. So this included a longitudinal study of Australian children, the Mexican Family Life Survey, the Millennium Cohort Study in the UK, the National Income Dynamics Study in South Africa, and then 4 countries participating in the Young Lives Study, so Ethiopia, 2 states of India, Peru, and Vietnam. So economic circumstances, they were varied in what were available in each country. In Australia and UK, for instance, only household income was available, whereas in South Africa, all 3 measures were available. Also, the age to which economic circumstances were measured at baseline varied across country, with the age lowest in the UK at 14. Our outcome was internalising symptoms as assessed through 4 different scales. This included in 5 countries the emotional symptoms subscale of the strengths and difficulties questionnaire. And again, there's slight variation across countries at the age at which this was measured. And then within each country, we standardized scores of the scales to enable cross-country comparisons of regression coefficients. So this is the results for countries where household income was available. So within the forest plot here, the values refer to change in internalising symptoms as household income doubles. And this was after adjusting for gender, household composition, specifically whether adolescents' parents still live with them, country-specific measures of minoritized status, and internalising symptoms at baseline. So you can see within the figure, there was, in each country, there was very little or no association with internalising symptoms, and also there's very little cross-country variability in the association. However, when looking at countries that had available data on household consumption expenditure, the picture is slightly different. There's much greater variability in the strength of the association between the 6 countries. Notably in Mexico and South Africa, there was no association, whereas in Vietnam, there was a much greater one. And then finally, for subjective wealth, again here, negative values indicating fewer internalising symptoms as subjective wealth of adolescents increased. There was some variation again. Now looking within countries and how the variance explained by different measures varied. Within the 5 countries where measures of subjective wealth and at least one measure of objective economic circumstances was available, we generally found that subjective wealth was more closely related to internalising symptoms than objective measures. And this is generally in line with findings from past studies. However, these have primarily been carried out in high-income countries previously. So to conclude, we found that there's variability in the association between household consumption expenditure and internalising symptoms. This partially might be an artifact of the methodological differences between the studies we included, specifically the use of different outcome measures to assess internalising symptoms, and also the ages at which exposure, economic circumstances, and internalising symptoms was measured. The differences might also reflect important role of societal context within countries that may shape these inequalities. For instance, countries differ in a variety of different important factors, such as welfare policies, accessibility and quality of healthcare services, and different cultural factors that may buffer the impacts of economic adversity. And also, the findings may reflect differences in the mechanisms through which economic circumstances impact adolescents' mental health. However, studies that have looked at mechanisms linking economic circumstances to internalising symptoms are very sparse, particularly outside of North America, where over half the studies we identified within a systematic search were conducted in the US, with particularly very few studies carried out in Africa or South America. And of the studies that we did find, over half were interested in mechanisms linked to parenting practices or parents' mental health. And this builds on theoretical work based on the family stress model and the family investment model, which emphasize the role that economic circumstances can have on different parenting practices and therefore adolescents' outcomes. And within these studies, only a very few were carried out outside of Europe and North America. Most were cross-sectional, which in terms of mediation studies leads to a very high risk of bias. So therefore, we wanted to build on past research by including countries that hadn't typically been studied before, and also improve the data quality by using longitudinal data. So therefore, we analysed the 4 countries taking part in the Young Life study to look at whether adolescents' relationships with their parents mediated the association between economic circumstances and internalising symptoms. So we included 2 different economic circumstances measured at age 15, consumption expenditure and subjective wealth. The mediator adolescent-parent relationship quality was measured and self-reported by adolescents at age 19, and then the outcome, internalising symptoms, was assessed at age 22 based on the emotional symptoms subscale of the Strengths and Difficulties questionnaire. Analyses were causal mediation analyses, and we adjusted for a range of baseline and intermediate confounders. However, we found that in no country was adolescent-parent relationship quality a mediator of the association between economic circumstances and internalising symptoms, which contrasts all the past research, well, the majority of past research that's been carried out in Europe and North America that has found that in fact it is important for adolescents' mental health in regards to how economic inequalities in mental health develop. So these differences in countries might be due to a variety of things. It might be due to differences in methods, in particular the more robust data that we've used, the causal mediation analyses, and the fact that we've adjusted for a wide range of confounders. Typically, previous studies have also included adolescents that are younger, whereas our sample were 19 when parental relationships were measured and 22 at the outcome. And perhaps that parenting factors are less influential on adolescent outcomes in later adolescence compared to early or mid-adolescence. Well, finally, our findings could reflect differences in context and therefore differences in mediators through which economic circumstances affect adolescent mental health. For instance, we may not have found any evidence of mediation in these countries, potentially due to differences in family structures and caregiving norms. For instance, in the countries studied, caregiving roles are much more equally split between wider family members, whereas in countries typically in Europe and North America, parenting is Child rearing is much more carried out just within a nuclear family unit by parents. So within the country studies, it's feasible that kind of wider family members buffered any negative impact of strained parent relationships with adolescents. So overall, the implications of the research, the studies caution against using findings from one country to infer about another. This is because economic inequalities in adolescents' mental health appear to vary across place, and that could be partially due to the important influence of the wider societal context. And ultimately, we need greater country-specific knowledge of the risk factors for mental health problems in adolescents, particularly in low and middle income countries where mental health data is typically scarce, yet 90% of adolescents live. Big thank you for listening, and thanks so much for my PhD supervisory team, lived experience advisors, collaborators, and funders of Wellcome Trust.
Thanks, Tom. That was exactly 20 minutes as well.
So oh, fantastic.
Does anybody have questions? You can also, if you don't want to unmute and talk, although this is a very informal setting, and please do unmute and talk, you can also type them in the chat, and then I will ask them on your behalf. Okay, while people are thinking about questions to ask, can I ask a question? Can you share your thoughts on sort of the process of thinking about using data from such different contexts and how it has been for you?
So in terms of like collaborating with experts from countries, that's been incredibly valuable. I really appreciate the help and support from everyone, and relying on their contextual wisdom and understanding. In terms of like data sets, it's actually surprisingly easy to kind of get hold and permission of the data. So global school-based health survey, if anyone wanted to use it, is incredibly easy to access, and I think you just have to do a few tick boxes and download it from the WHO website. I think that's the same, well, similar format with a few other cohorts that I used that were longitudinal on. So I think I was expecting there to be more kind of administrative hurdles compared to if I just focused on the UK, but actually there might have been less. So that was nice. But then obviously, a lot of data management and admin that came with the work.
Okay, we have a question from Alexander. How are cultural differences accounted for when the variables are measured across so many different countries?
That's a very good question. So it's how to, like, where to start with defining culture and how the impact that might have within how adolescents experience mental health problems and their relation to the different economic circumstances measures. Very complex. Within the analyses of food security and suicide thoughts and behaviours, there was a massive variation in how commonly adolescents reported these outcomes, which might be reflective of true differences in how common suicide attempts are, but probably are massively influenced by different cultural understandings of suicide, kind of national laws, and kind of stigma around suicide as well. So, and there's not really a way to counter that within that study. So that's an important factor that undoubtedly has some implications on results and influences the findings, but how, I don't fully know, I'm afraid.
I think just to also add, because here we're not comparing sort of prevalences across countries and things, so the measure being interpreted differently and stuff is important, but the goal is really to think about within that country where people sit on the distribution and what predicts the rank ordering within that population. So to some effect, I think it is easier, or not easier is the wrong word, but I think it's more plausible to draw inferences from this type of cross-national research, which is still interested from within country predictors and stuff, and then comparing those, rather than, for example, comparing prevalence and things like that, because obviously when you're comparing prevalence, you could, like, it becomes more important if the sort of questions are interpreted differently and stuff like that. Okay, we have a question from Alexandra, and this is going to be last question, which is, did any of the visits to the sites or to the countries provide useful context to understanding differences in what you saw?
So not so far, but only because the only country I've so far visited, we ended up didn't get the data. But hopefully, I am traveling to India to meet with the study leads there of the Young Lives cohort, so that would be really valuable too in interpretation, and that's something I'm really looking forward to. But yeah, very important point. Thank you.
It's worth mentioning that most of Tom's PhD happened during COVID, and like traveling anywhere, it's not possible. So this is late stage traveling. Brilliant. Thanks so much, Tom.
Thank you.
If I will go to Kelly now, but we will bring you back. So stay on the call. So bring you back for the panel discussion later. Kelly, are you here? Yes, you're here. So very, very pleased to introduce Kelly Rose-Clarke. She's a Principal Research Fellow at the UCL Institute of Global Health. She's recently come back to UCL after leaving to King's for a few years, although she was at UCL for many years before that. So we're very, at least I am very happy that we've brought her back to UCL and that she's going to hang out with us again. She is a mixed methods researcher and has a UKRI Future Leaders Fellowship. And her work focuses on understanding and testing ways to improve child and adolescent mental health in low resource settings. And it's worth mentioning for those of you who already don't know Kelly that many years ago, even at UCL, she's always been really interested in how to get things done in low resource settings, including in the UK, because in many ways, the UK is also a low resource setting for some things. And she ran a really cool program called Open Minds, which was designed to get students from universities talk about mental health in schools with school students. So yeah, with that, I will hand over to Kelly.
Thank you very much. I'm pleased to be back and hanging out with you all. Share my slides. Does that look right? Yeah, great. All right, I'm not going to present lots and lots of analyses, so sorry to those of you who are disappointed. I am going to talk to you from my perspective as a global mental health researcher. I feel like global mental health research receives a lot of bad press, but I'm actually very proud to stand for my discipline. I think that global mental health has a lot to offer, not just low resource settings, but there have been some really interesting areas of innovation and creativity within global mental health that I think have generated ideas, interest, and are certainly inspiring for low resource settings beyond low and middle income countries and even high resource settings, the US, the UK. Particular areas of innovation, I've listed a few here. So task sharing, so training and engaging non-mental health specialists to deliver mental health interventions in community settings. Low cost interventions, they're the bread and butter of global mental health intervention. Then thinking about the Lancet Commission on Global Mental Health and Sustainable Development in 2018 really focused the field and the broader field of mental health research on the importance of social determinants and community resilience in mental health programming and policy. So I'm going to talk about some of the organizations here that have been responsible for a lot of these innovations. There was a review by Misra and colleagues in 2019 that looked at almost 500 papers that have been published in the field of global mental health research. And they found that among those, more than half of them originated from 5 countries: India, Nepal, Uganda, Ethiopia, and South Africa. And the key organizations behind that research are here on this slide: Sangath in India, along with Public Health Foundation of India. And then in South Africa, the University of KwaZulu-Natal, the University of Cape Town in Ethiopia, Addis Ababa University, Makerere University in Uganda, and then TPO Nepal, Transcultural Psychosocial Organization in Nepal. And I want to focus on the last of those organizations, TPO Nepal, for the rest of this presentation, mainly because I have had the great privilege to work with this organization since 2018 on several projects. TPO Nepal itself was established about 19 years ago in Nepal, and there is not a single thing this organization doesn't know about global mental health policy, programming, and research. They have superb relationships with government at all different levels, as well as global policymakers. And I've learned huge amounts through my work with them. A couple of the projects we've worked on together are here: the SMART project, which is a sports-based mental health promotion intervention for adolescents in rural Nepal. And the one that I want to talk to you about today is the SATI program. SATI was an acronym for this program, and we've all long since forgotten what the letters stand for, but the name remains. The project is an adaptation and evaluation of a talking therapy for adolescents with depression. Here are my wonderful colleagues. Let me tell you more about the work we've been doing. So this talking therapy, it is interpersonal therapy that we've been adapting and testing in Nepal. For those of you who don't know interpersonal therapy, it's more popular in the US. It's a little bit like cognitive behavioral therapy in the sense that it's time limited, can be delivered on an individual one-to-one basis or in groups. Our interpersonal therapy intervention looks like this. It's based on the WHO's, the World Health Organization's manual. It has 10 group sessions, and before that, 2 individual sessions. The individual sessions, one with the adolescent and the facilitator alone, one with the adolescent and their parent, and the group sessions being split into initial, middle, and termination phases. IPT is built on the idea, sort of central concept is that depression is almost always triggered by 4 interpersonal problem areas. And those problem areas are dispute, so conflict, argument, grief, loneliness, social isolation, or role transition. And IPT has strategies and techniques related to each of these different problem areas that through the group sessions, adolescents learn and then implement with the support of the facilitator and their group members. So we started working on IPT in Nepal in 2018 with a UKRI MRC grant. And this involved adapting, so culturally and developmentally adapting the WHO IPT manual, which was it was a group-based version of IPT, but for adults. And then testing the feasibility of this in a one-arm pre-post feasibility evaluation. We adapted the intervention through interviews, focus group discussions with parents, teachers, adults, adult caregivers, and other community stakeholders. And these suggested that the intervention should be adapted for schools, and could be delivered by school nurses or local people from the community with sufficient training. And we saw from the feasibility study that this was an acceptable intervention. Adolescents came, good start. Facilitators could be trained. We saw some nice trends, promising trends in terms of mental health outcomes. And above all, it was a low-cost intervention that was acceptable from a policymaker perspective. So then we got a bit big for our boots, and we thought we might want to do a bit more on IPT in Nepal to test it in a fully powered randomized control trial. But we also saw an opportunity to do something a bit cool, a bit different. And the literature in this field, whilst there are some trials of talking therapies in low and middle income countries, there aren't loads. And among those trials, there are quite variable results, quite different results, and different levels of acceptability. So for example, I'm thinking of the biggest trial, or the most important trial probably, of IPT for adolescents in low and middle income countries was in Uganda. And they showed that it worked for girls, but not for boys. In other settings, there's been, high dropout rates and low levels of attendance. So we really wanted to explore this to try and find out what was going on, in addition to testing whether IPT works or not in Nepal. So to do this, we're using quite a neat technique called a realist cluster randomized controlled trial. The brains for this comes from Professor Chris Bonnell at the London School of Hygiene and Tropical Medicine, whose group has done quite a lot of work to flesh out this method and test it in a UK school setting. Sorry, my laptop has decided that I'm talking too much and it's just skipping forward. So a realist cluster randomized control trial is interested in testing at a population level whether an intervention works, but it's also interested in the how, so the mechanisms, interested in working out who an intervention might work for best, so subgroup effects, and thinking about the contextual factors, so macro and interpersonal factors that influence the way in which mechanisms interact, the way in which mechanisms lead to mental health outcomes. It's, you can kind of think of it as a conventional randomized controlled trial, but with a healthy dose of realist methods integrated. So the main difference between RCTs and realist RCTs is this, well, as I say, that the RCTs will look at a population level. But the problem with this, particularly where there have been quite variable results for an intervention, is that you might risk scaling up with small population level effects and therefore widen the health qualities in a particular setting. Realist RCTs focus on mechanisms and generate mid-range theories. So this is theories about intervention processes, which can then help policymakers to decide whether an intervention tested in one setting might therefore be useful and effective in another setting. The main focus of the realist component of the realist cluster randomized trial, the realist randomized trial, are these context mechanism outcome hypotheses. These are a priori testable hypotheses that are developed on the basis or generated on the basis of existing literature, formative research, and intervention theories of change. And they link these three components: context, mechanism, and outcome. So some examples in the context of our study in Nepal, so thinking about a school-based talking therapy for adolescents with depression, a couple of example CMO hypotheses are here. So adolescents participating in IPT at schools where there is stigma towards mental ill health, so the context being the stigmatizing school setting, will have smaller reductions in depression due to continued interpersonal stress, so the mechanism relating there to the continued interpersonal stress. And a second one related to adolescents with a family history of mental ill health or substance use, being less likely to be able to resolve their interpersonal problems and therefore not able to reduce their interpersonal stress to the same extent, hence smaller reductions in depression. The idea is that you can then conceive of quantitative analyses that you can do to test these CMOs, not every particular aspect, and certainly you can use qualitative work to elaborate or refine some of these CMOs, but ultimately the idea is that you would then go on to test them through mediation and moderation analyses. This phase, the realist cluster randomized trial phase, began in August 2022. So we started off doing some formative research to try and generate these CMO hypotheses. So we did a realist review of adolescent psychological interventions, systematic review of IPT mediators and moderators. We got together the global community of IPT practitioners and researchers to get their ideas about how IPT works, for whom and in what circumstances. And then we reanalyzed a lot of our exit interviews from the feasibility study we'd done in Nepal. So then we got our CMOs and we conducted a pilot realist cluster RCT. So to get our methods sorted, refined, the training protocols, the standardized operating procedures, the measures, etc. And we've just finished up there. Then in April, we'll start the phase 3 cluster RCT in 48 schools with just over 700 adolescents. And that will include a cost effectiveness analysis as well. And the data generated through that cluster RCT will then use to test the CMOs and ultimately refine our theory of change. It's a bit early in the day to share findings from the pilot RCT, but I just want to give you a quick look. So we did a baseline survey with adolescents. So this is a 2-arm cluster randomized trial with 8 schools, 4 allocated to receive the IPT intervention, 4 to control. A minimal number lost to follow-up. 80 adolescents receiving the control condition in the 4 schools and 81 receiving IPT. And those participants were subjected to 5 surveys conducted by RAs, separate from the research, separate from the clinical team. Baseline, 2 midline surveys, end line, and a follow-up approximately 3 months after they finished the treatment. And we've got some nice looking results for depression, which is the primary outcome, that were held at follow-up, which is great to see. And large effect sizes too, so standardized effect sizes of 1.23, which is large even for a treatment intervention. And we see this really interesting phenomenon around this sort of sudden gains phenomena. So the real drop, both in intervention and control, but increase in a larger sudden gains effect in the intervention arm. We see similar trends in post-traumatic stress symptoms, in functional impairments, in anxiety, and in quality of life. So some really nice, obviously not powered to look at effects, but some very exciting results, which hopefully will stand us in good stead for the full trial in the coming years. It's very easy to focus, I think, on the research innovations in this study, the cool methods, the vast amounts of data we'll generate, but it's also really nice to see the amazing work that the clinical team, they're all here for you to see, are doing. It's a really tricky place to work. The training that goes into preparing the facilitators, these IPT facilitators who don't have a background in mental health, they finished their high school education, and many of them are between high school and going on to do their bachelor's. Some of them not going on to the bachelor's. but the training and supervision that's required is really involved, and our clinical coordinators do an amazing job. They've developed high-risk protocols, so we see a really high level of suicidal behavior among these adolescents. And in a low-resource setting where we're essentially the only provider of mental health care, it can be incredibly demanding to try and manage all of these cases and keep everyone safe whilst also trying to do some research. They've also developed a really interesting way of operationalizing competency and fidelity assessments, so ensuring that the training that they're doing is working, and that it is actually IPT we're delivering on the ground, and then using these assessments to inform the training, the ongoing refresher training, and above all, work to support each other. So I think what often gets neglected in this field, it's great that we can do task shifting or task sharing, that we can train non-specialists to deliver these psychological interventions, but actually what that needs to go hand in hand with a really good system for supporting the emotional well-being of the people that we're asking to do these interventions. And I think that TPO Nepal and the clinical coordinators on the team are really excelling in managing this. So as a team, we're focused on the bigger picture. Our work, we hope, will contribute to the provision of evidence-based therapies for adolescents with depression. We have a long-term vision that we can use our data to help optimize and streamline IPT, make it more cost-effective in Nepal, but also potentially other settings, and perhaps a longer-term goal to move towards data-driven selection of therapies. That's my computer telling me I've spoken for long enough, so I'll finish there. Thanks.
Thank you, Kelly. Also on time. This is very an easy seminar to chair. Again, can we have questions, please? And while people decide to either talk or type questions, I will ask the question. This is actually something you said right at the beginning, so I feel bad for asking a question about it. But you know the slide where you said about 50% of the global mental health research in low-middle income settings happens from 5 organizations. I mean, isn't that a problem? Like that, you know, this is representing most of the world's population and 90% of the world's young people. And there's 5, I mean, imagine if we said that about mental health research in the UK, you'd have a gazillion groups doing this stuff. And the fact that you can name 5 organizations that are doing 50% of the youth mental health research in 90% of the world, seems like that shouldn't be the case. And I know you said it as a positive, but I'm going to be difficult and be like, isn't this a problem? Like take Sangat, for example, India, 1.4 billion people. Isn't it a problem that one research organization is mainly doing the mental health research in this ginormous country with an enormous population? Just to sort of declare conflict of, I'm currently sitting in India, so I sort of just drawing on that as an example. Yeah, what do you think?
Yeah, I fully agree. I don't think it's positive at all. Just to say that review was conducted, I think it took papers up until 2016. And I think things have changed quite dramatically. The one thing about global mental health research that I'd say is that it does listen to criticism and it does change its ways. And I think that it has changed enormously and I think expanded in terms of the country context within which it works. But I agree, I think that the field has been dominated by work from particular settings with their own kind of agendas and political leanings. And I think the more diverse we can make, you know, the more settings that we can involve in global mental health research, the better. So I agree with you.
Okay, any questions? Nobody has typed. Does anybody want to put hand up and ask a question? Kelly, it was such a clear presentation. That was so interesting. And nobody has clarification questions. Oh no, we have a question. Oh, So the question is the research you just presented with TPO being done with a particular research group, which is your research group, but do you want to answer?
No, that's clear. Yeah, thanks so much. Yes, we're IGH, so my group at IGH are working with TPO on this research. So we'd love to hear from anyone who's interested in global mental health research and Nepal research, or more broader global mental health research.
Brilliant. Any other questions for Kelly specifically, or shall we open up for like broader discussion? For broader discussion, and I really hope people will take part. And just to say, for this next sort of more open panel discussion, please feel free to jump in if you have thoughts to add as well. And just to get us started, because it's good to have something prepared to get us started. I was going to ask a question to Tom and Kelly to comment on, but then for anybody else who's joined us today to also add in, is traditionally UCL hasn't been a stronghold of mental health research in the rest of the world. And I suppose given we have such a big mental health research community, I think one of the biggest mental health research communities in Europe, what can people do who are already doing research in whatever area they're doing research in, but are interested in extending this research to other settings? What can people do to get more involved in thinking about research, especially in children and young people's mental health in settings outside the UK or the settings that they already study? Which of you wants to start? Kelly, you're not muted, so I feel like you should start.
Oh. So what can people do if they want to do more research, more child and adolescent mental health research in low and middle income countries? Is that what you're?
Well, in places outside the UK, or places where child and adolescent mental health research is not usually done as much, I suppose.
Yeah, it's a good question. I think at UCL, there's a lot of work with really fantastic global health partnerships, certainly within our department, long established sort of platforms for knowledge exchange and mutual learning with countries, beyond the 5 that I mentioned. And I think trying to identify those countries, those partnerships, and then trying to understand what the priorities for that partnership might be and where mental health might fit, it is a good start. And they don't have to be partnerships, that are necessarily already working on mental health, but so for example, there's an increasing focus on chronic disease, non-communicable disease. And I think that's an obvious place to start to do some work on mental health. So yeah, I'd say that's not a bad place to start. I mean, I think that obviously it's the way to work in this field is sort of in the provision of technical support rather than necessarily leadership or project implementation. Ultimately we should be doing ourselves out of a job as global mental health researchers and finding ways to support people in those countries that are underrepresented from a research perspective. And I think to kind of have a real conversation with ourselves about what can we offer to do that, to help support these partnerships and these in-country organizations, and the skills that we can bring to the table. And I think particularly at UCL, there's a lot of expertise in terms of evaluation, in terms of trial design. So thinking about Agiris Rangaris's thoughts around how to do control conditions, intervention conditions, how to do more sophisticated trials of psychological drug treatments, then thinking about the expertise that we have in terms of how we might evaluate the impacts of these kinds of mental health interventions. So thinking about biological, psychological, genetic, cognitive, social evaluations that we can support in-country research with.
Thank you, Tom.
I mean, that was a very thorough and hard act to follow. I think kind of from my perspective, I'd recommend chatting to Kelly Praveetha because they're great colleagues, and I'm not just saying that because they're in the call. And also, I think when I first started my PhD, it really wasn't obvious kind of what data sets and who to work with were available, and there wasn't people who I could really discuss how one data set might work and how best to look at it. So I think, yeah, just try to look for people within UCL who have looked at different data sets across countries, and perhaps we could be better at setting up kind of visibility of what data is available and where, and data access requirements. Because at UCL, we're very good at obviously knowing what's available within the UK and the British birth cohorts, but we perhaps don't have that awareness beyond that context.
Thank you. Any questions from the floor? I just noticed Alexandra made a really good point about there's a global engagement fund at UCL, and we have also applied for it. It was one of the ways we got money to meet collaborators in other countries and set up collaborations, which is, I think sometimes it's really nice to meet people in real life and spend time with them, and in that context to set up even if you're going to analyze secondary data. So that is one thing to look out for if you're really keen to get started and need some seed money to sort of kick things off. Yeah, if there are no other questions, given it's 2 o'clock, I will wrap us up. But just to sort of say that so as we've all highlighted, there's a lot of child and adolescent mental health research that needs to be done in the world, and it's not being done because there's so few of us trying to do it. So if people are interested, curious, do get in touch with any of us or anybody else you know who's doing this stuff. And just if you're interested, it is not as, it might seem like a difficult thing to get started on, but it's so interesting, and you work with such interesting people, and the world is such an interesting place with so many different contexts, and that it is a very rewarding thing to do, and I hope more people will consider it. And if you are considering it, do get in touch. Thank you very much.
Thank you very much. I'll end the session. Thank you, everyone. Bye.
Thanks, bye.